without further ado, I will introduce our CML conversation in March. We're very privileged to have Professor Sue Branford talking with us today on genomics and mutations in CML, a very hot topic, and really about the assessment and risk involved with that. So a brief introduction to Professor Branford. Professor Susan Branford is head of the Leukemia unit at the Department of Genetic and Molecular Pathology at the Centre for Cancer Biology, SA Pathology, and the University of South Australia in Adelaide. Her research focuses on the molecular analysis of patients with CML treated with TKIs to investigate predictors for treatment response and the mechanisms of drug resistance. Sue is a leading international authority on molecular monitoring for CML and a major contributor to the international collaborative initiatives to establish guidelines and recommendations. And she also chairs the ICLF Genomic Alliance. So again, welcome everybody. And I will now hand over to Professor Susan Branford. Thanks, Sue.
Thanks, Nicola, and hello to everyone. Right, so as Nicola has said, I'm going to be talking about mutations today. And we all know that CML is a genetically uniform disease where all patients have the BCR-ABL fusion, and survival with imatinib therapy has markedly improved over the last few decades. But not all patients respond optimally. A proportion of patients still fail therapy due to drug resistance. And still some patients progress to the blast phase, where treatment options are limited. So a better understanding of the mechanisms of drug resistance could lead to more effective therapeutic decisions. Now we know that the rate of BCR-ABL decline is a really powerful predictor of outcome, and those patients who fail to reach their treatment milestones or lose their response have drug resistance, and they are at risk of disease progression and even death. Now, we know that mutations within the BCR-ABL kinase domain cause drug resistance, and shown here is the crystal structure of BCR-ABL in complex with imatinib. And we have found mutations scattered throughout the kinase domain. And sequencing of the kinase domain is the principal test for resistance assessment. This is the principal molecular test, and bone marrow cytogenetic analysis is certainly important for some patients. Now we use Sanger sequencing, and we've used this for many years, but it does have limited sensitivity of about 10 to 20%. But we can actually achieve exquisite sensitivity to detect these mutations very early on as patients are developing resistance. Because every leukemic cell has the BCR-ABL gene, we can isolate this allele by PCR, and we can even find mutations in patients with minimal residual disease as resistance is emerging. So there are lots of mutations, they're scattered throughout in the different domains, and some of them are more problematic than others, in particular, the T315I mutation that causes resistance, not only to imatinib, but as well as the second generation TKIs. And about half of the patients who acquire resistance gain one or more of these BCR-ABL kinase domain mutations. And it's drug resistance that has driven the development of more potent BCR-ABL inhibitors. But for each of the second generation inhibitors, we know that there are specific BCR-ABL mutations that cause resistance, including the gatekeeper, T315I. And the National Comprehensive Cancer Network guidelines are updated, I think they're about 4 times a year, and they have a very nice table in their guidelines that lists the contraindicated mutations for each of the inhibitors. For example, if a patient has an F317L BCR-ABL mutation, they're more likely to respond to nilotinib than to dasatinib or bosutinib. And for ponatinib, the T315I mutation is sensitive. And there is some reports suggesting that compound mutations, and now compound mutations are those where BCR-ABL mutations occur on the same molecule. rather than on individual clones, and these may confer ponatinib resistance. Now, these have been more frequently found in advanced phase diseases, and a study a number of years ago showed that compound mutations in BCR-ABL are actually not major drivers of resistance for patients who maintain their chronic phase of CML. And if we go back to the NCCN guidelines, there are actually no contraindicated mutations for ponatinib. And asciminib has been approved now for resistant patients, and it's in clinical trial for newly diagnosed patients. But we know that there's a new spectrum of BCR-ABL resistant mutations, and these occur mainly in the drug binding site, which is the myristoyl pocket. And again, if we have a look at the NCCN guidelines, just in their last version, they have now introduced contraindicated mutations for asciminib. But interestingly, they only list 2 mutations, despite the fact that almost 5 years ago, there were other clinically resistant mutations that have been published, as well as others subsequently. So hopefully in the next iteration of the NCCN guidelines, there might be more mutations that we now know have been associated with asciminib resistance. So characterizing the type of kinase domain mutation is essential for treatment decisions. And BCR-ABL kinase domain mutation analysis plays a critical component for patient management. So when to test for these mutations, will failure to reach the milestone responses, any signs of loss of response, and this can be hematologic, cytogenetic, or loss of a major molecular response with rising BCR-ABL, and certainly with disease progression. But we found that there's no indication to perform mutation analysis at chronic phase disease. We simply don't detect them at that time point. But what I would suggest is that you should always collect a sample for mutation analysis before the patient ceases their TKI therapy, if possible, because we know that unmutated BCR-ABL can rapidly and preferentially proliferate in the absence of BCR-ABL inhibition. And this can lead to a false negative mutation result. And this can be quite dangerous because it means that some mutations could rapidly expand if the patient receives an inhibitor for which the mutation is resistant. And we know that more sensitive methods can enable the early detection of kinase domain mutations. And one of the first methods to demonstrate this was a high throughput multiplex mutation genotyping method using a chip-based mass spectrometry. And this achieved very high levels of sensitivity, down to 0.5%. And what we found was that mutations below the detection limit of Sanger sequencing were very frequent in patients with imatinib resistance who were subsequently treated with nilotinib or dasatinib. And these low-level mutations invariably expanded when the patient was treated with an inhibitor if the particular mutation conferred resistance. So low-level BCR-ABL mutations are clinically relevant. But interestingly, we also found that patients who had more than one low-level mutation also had a poorer outcome. And this was irrespective of the mutation resistance profile. And here's an example of a patient who had one predominant mutation that is sensitive to nilotinib. The patient was treated with nilotinib. Here's a plot of the BCR-ABL levels. The patient had a good response. In contrast, here's another example of the patient with the exact same mutation, was treated with nilotinib, but using a more sensitive technique, we could detect 7 low-level mutations. Now, these were all predicted to be sensitive to nilotinib, but in this case, the patient had a poor response and acquired a T315I mutation. So it could be that having a lot of these low-level mutations could be a marker of genomic instability, potentially indicating that the patient is at risk of acquiring more kinase domain mutations. Now, next generation sequencing techniques are now being used for BCR-ABL mutation detection. This certainly has enhanced sensitivity, where the limit of detection is 3%. But it's important to appreciate that the assay needs to be carefully optimized. Distinguishing low-level variants from background artifacts does remain a major challenge. But studies have shown that NGS detected the early appearance of clinically relevant mutations that would not otherwise be detected by Sanger sequencing, and this confirmed the prior findings. So NGS will allow early clinical intervention and ideally, and hopefully, will improve patient clinical care. So I'm just going to show an example of NGS performed in our lab and showing that it certainly is more sensitive than Sanger sequencing. So on the top right-hand panel, this represents the Sanger sequencing, it's the NGS sequencing, where the sequencing reads are visualized using the integrative genomics viewer. So each one of these gray rows represents a sequencing read, and we can see that at one of these points, there is a whole series of Ts. So this is showing variation from the reference sequence. In this case, it was a T315I mutation at 3%. Now, we couldn't detect this mutation by Sanger sequencing, and the patient was treated with dasatinib, and as we would predict, there was rapid expansion of this T315I clone as early as 4 months, and the T315I BCR-ABL increased to 23%. And there's been a lot of work done in Europe using NGS, and viability studies were performed across 43 collaborating labs in Europe, and this confirmed the accuracy and, importantly, the reproducibility of the assay. So the European Leukemia Net, in their 2020 recommendations for treating CML, recommend that NGS should be used to monitor patients. It is a recommended technology for patients not responding adequately to TKI. But there's still an unmet need. And here's an example of rapid progression in a 21-year-old female. So she developed lymphoid blast phase at 6 months and died after an unsuccessful allogeneic transplant. So we can see by her plot of BCR-ABL that where there was no reduction, that this patient had primary resistance. Sanger sequencing was performed at 6 months, and we detected a kinase domain mutation, and at that time cytogenetic analysis also revealed additional chromosomal abnormalities that were not detectable at diagnosis. And again, we know that BCR-ABL mutations are not the cause of primary resistance. So what we did a few years ago was went back to the diagnosis sample that we had stored in our freezer for many years, and we performed NGS analysis. But this time we performed whole exome sequencing, RNA sequencing, and copy number analysis. And we were searching for mutations in other blood cancer-related genes. And we did detect a mutation. We detected an IDH1 R132H mutation. Now, this is a really common mutation in many cancers, in brain cancer and acute myeloid leukemia. The mechanism is known. It contributes to a transformed phenotype, and the first inhibitor of this mutation was approved in 2019. But it's not approved for CML, and we don't know how this patient would have responded if they had availability of an IDH1 inhibitor. But with the rapid progression to blast crisis, interestingly, what we found was that with the emergence of the BCR-ABL kinase domain mutation, the variant allele frequency of the IDH1 clone declined. So it was about 40% at diagnosis, but it had declined to about 5% at the time of lymphoid blast crisis. But in addition to the kinase domain mutation, we detected another mutation. And again, this is a known hotspot mutation in a gene called XBO1. And again, this mutation in this gene are common in many lymphoid cancers, including CLL and various lymphomas. And remembering that this patient had a lymphoid phenotype. This is a key mediator of nuclear export, and selective inhibition of nuclear export is certainly a promising approach for treating various blood cancers. So this was a good lesson. It showed us that clonal competition among evolving clones may contribute to the blast phase phenotype. And over the last many years now, perhaps over the last decade, there have been many studies using NGS and have found that cancer, blood cancer in particular related genes, have been detected in patients with CML. Now, the vast majority of these studies have focused on patients at diagnosis or at disease progression. So there's lots of work being done around the world. So this led to the formation of the International CML Genomics Alliance that was formed in 2018. And the aim of this group is to harness the wealth of this genomic information that's being generated in the various research projects around the world. And we aim to share this data so that we can pool it and for improved statistical power to really understand the clinical relevance of these mutations. Now, one of the first things that we did as a group was to look at all of the published data. And we did find quite a bit of data and published a review article on what we had found and what we knew so far at that time, which was in 2019. And shown here is the mutations that we found in patients. There were 500 patients included in this, and shown here are the studies that focused on the detection mainly of single nucleotide variants or small insertions and deletions. But some of the studies also included the detection of deletions in IKZF1, and these are common in lymphoid blast crisis as well as acute lymphoblastic leukemia. So at diagnosis, we found by far the most frequently mutated gene was ASXL1. It was detected in 10% of patients. And again, this is a really common gene in myeloid, commonly mutated gene in myeloid malignancies, and it is known to be associated with a poorer outcome. And in advanced phases, as we would expect for these mostly TKI-treated patients, BCR-ABL kinase domain mutations were detected in about 39%. But there were 3 genes that were the most frequently mutated: RUNX1, again ASXL1, as well as IKZF1 deletions. So collectively, these cancer gene mutations may actually be more frequent in advanced phases than BCR-ABL kinase domain mutations. Now, some of these studies were also able to demonstrate that BCR-ABL mutations rarely occurred in isolation in blast phase. So the majority of patients had BCR-ABL mutations plus 1 or more mutations in other cancer-related genes. So as mentioned, most of the studies have been performed using highly selected patients. And we published a paper a few years ago where we did the same thing. We selected patients who had the very best outcome and compared to those who had the worst outcome. Most of these patients had very rapid progression. And shown here are the mutations that we detected. And we found a significantly higher frequency of these cancer-related gene mutations in those patients who went on to have a poorer outcome. But interestingly, we still did find some mutations who had an optimal response. We found 2 patients who had a single ASXL1 mutation, and these 2 patients achieved a major molecular response. A similar study from the Hammersmith Hospital found that those patients treated with imatinib who had these cancer-related genes at diagnosis had a significantly poorer progression-free survival. However, for those patients who were treated in the first-line setting with a more potent inhibitor, this difference in progression-free survival was not seen. So I think this was a really important study because it suggests that mutations in key genes at diagnosis could influence treatment decisions. And other studies of patients in advanced phases using multi-omics have shown that blast phase is characterized by additional translocations and deletions, so not only IKZF1, which I mentioned earlier, but also other genes such as CDKN2A and PAX5. And by using RNA sequencing in blast phase, we found that gene fusion transcripts are also relevant. And we sequenced 39 patients, again using whole exome sequencing, copy number variation, and RNA sequencing in 39 patients. We found that more than 70% had mutations, frameshift nonsense, splice affecting mutations, and missense. But we also found cancer gene fusions in 31%, and these are some of the same fusions that are detected in other, usually myeloid leukemias involving RUNX1, KMT2A, CBF-beta, MYH11. And using copy number variation, we also detected a high frequency, 36% of deletions in these same genes that I've already mentioned. Now, most of these were detected in patients who had lymphoid phenotype disease. So by using these various detection techniques, we found that 100% of patients in blast phase had one or more mutated blood cancer related gene. And about half of the patients had BCR-ABL mutations, and every one of them had cancer-related genes. So again, this shows that BCR-ABL dependent and independent resistance mechanisms frequently co-occur. And why this is important is because these mutated genes may be targets for future or current therapy. And there are now a number of inhibitors that are either in clinical trial or in development. So what we've been doing is focusing on the fact that we're finding SNVs, indels, gene fusions, gene deletions, and we've tried to develop a technique, a single technique where we can detect all of these in the key genes that we found to be relevant. So we have developed a small hybridization capture panel of about 100 genes relevant for CML to detect all of these genes. And we've been using an RNA-based method because we can not only detect the SNVs and indels, but we can detect specific gene deletions and, importantly, gene fusions, which I think are going to be important for advanced phases. And we can also assess the functional effect of splice region variants because we can see differences in splicing. But a few points about NGS at diagnosis. It's still in the exploratory phase, although we've been working on this for a long time. We're certainly not as advanced as many of the other leukemias where they have introduced all of the genomics into their diagnostic categories. So we're still establishing what the clinical relevance is. There's still a lot of questions to answer. We don't know whether some mutations could confer a poorer prognosis than others. It could be that having multiple mutations may have a greater impact than a single mutation. We don't know yet completely whether poor risk can be overcome with more potent inhibitors. We don't know what effect this will have. Having a mutation at diagnosis will have on future treatment-free remission. So a lot of these questions are the same that we addressed about 20 years ago when we were first assessing BCR-ABL kinase domain mutations. And as we've seen from the asciminib studies, there are always new mutations that may emerge with resistance. So with the International CML Genomics Alliance, we're aiming to answer these questions, and we've partnered with the European-based Harmony Big Data project. So how this works is that it's a central repository of anonymous data of patients with various types of blood cancer. The access to the data is secure and for approved projects only. And we have an approved project in CML, it's called Clonal Hierarchy, and data submission is underway. And what we're really aiming to do is have more than 1,000 data sets. And we've got biostatisticians and bioinformaticians with expertise in the analysis of CML from both Germany and Adelaide, who are learning how to use the Harmony platform for analysis of the data. And we hope that this submission will be completed in about the second half of this year. So what we're aiming to do is to discover biomarkers that could predict treatment response and progression and guide drug use and development. And we want to identify clinically relevant prognostic subgroups for enhanced risk stratification. And we want to provide data for evidence-based expert international guidelines. Now, I've mentioned a lot about the NCCN. They're very proactive and they frequently update their guidelines. Now, for a year or so, they have already included the suggestion that myeloid mutation panel testing should be considered to identify BCR-ABL independent resistant mutations in patients where no BCR-ABL mutation is identified. But I think there's a lot of problems with this. Firstly, there is no guidance for patient management if a cancer gene mutation is detected. And we know that cancer gene mutations frequently co-occur with BCR-ABL mutations, and these could potentially modify response to subsequent TKI. And we know that focusing on myeloid-specific genes will not detect IKZF1 deletions and other gene deletions that we know predominate lymphoid CML phenotypes, and it won't detect gene fusions that we know are associated with disease progression. So hopefully when we can provide some evidence for these guidelines will be improved. So I'm just going to finish with a couple of examples of how we have found that NGS is really revealing the clonal complexity of disease progression. Now, this first example was a 44-year-old male at diagnosis in chronic phase, was treated with imatinib, achieved a remission, but progressed to myeloid blast phase, was able to had early access to dasatinib, achieved his best response, but then he progressed again and died after 4 years. Now, we never knew what the resistance mechanism was for this patient. We never detected a BCR-ABL kinase domain mutation using our standard Sanger sequencing. No cytogenetic abnormalities were detected, but there was no bone marrow collected at second blast phase. So again, we performed whole exome sequencing, RNA-seq copy number variation, and we also more recently performed our sensitive gene panel testing, where we can detect each one of the types of variants that we're interested in. So I'm going to describe what we found. We tested this patient at 5 time points, and shown here is a fishplot, and this is a visual representation of inferred clonal relationships between mutant genes. So the size of the clone can give us an idea of the clonal relationship. So in blue is the representation of the BCR-ABL mRNA levels. And the point on the left, labeled 1, is a representation of the very first stem cell that acquired BCR-ABL. So this cell had a proliferative advantage and expanded to a very high level until it would be clinically manifested at diagnosis. So the width of this fish plot shows that there were very high levels of BCR-ABL at diagnosis, declined at remission, then expanded again at blast phase, etc. So the first thing we did was test at diagnosis, and we detected an ASXL1 mutation. This was a small clone. It was represented about 10%. But we can see that by the time of the first remission, that this tailed off to the point. So we no longer detected the ASXL1 mutation at that time point. But at diagnosis, we detected a second clone, and this was a novel gene, a SETD1B, that has subsequently been found mutated in other patients with CML. But within that clone, we now know that there was a very small, low-level U2AF1 hotspot mutation, and this is a splicing factor. And these mutations are known to be associated with myelodysplastic syndrome. Now, we didn't detect this initially using whole exome sequencing and RNA-seq, but we were able to detect it using our more sensitive targeted panel. And this was still detectable at first remission. And it was this clone that swept through and became the predominant clone at blast crisis. So the width now of this clone indicates that there were very high levels. There was a BCR-able clone that predominated that had both of these mutations as subclones. The clone continued to evolve, and while the patient was still in chronic phase, we detected another mutation in another cancer gene, PHF6. And at blast crisis again, the clone had evolved, and this time we detected a RUNX1 clone. Now, again, we know that RUNX1 is associated and seen very frequently in blast phase CML. This was a large clone, and there was a subclone within that one represented in yellow. Now, interestingly, this was an IKZF1 exon 4 to 7 deletion. It's a common deletion, commonly seen in lymphoid blast phase, but it has been described in myeloid blast phase. Now, interestingly, with this clone, we can see that at second blast crisis, we could no longer detect the IKZF1 deletion, and the RUNX1 clone had declined. It was only detectable at about 5%. And in this case, there was a minor second subclone at first blast crisis that this time swept through and was the predominant clone at the second blast crisis. Now, again, really interestingly, this was another independent IKZF1 deletion, this time exon 2 to 7. And within that clone, we detected another mutation. This is a CBF beta MYH11 fusion. So this was the predominant clone at the second blast crisis. So there were different clones driving the disease throughout the disease course. And if there had been cytogenetics performed at second blast crisis, likely an inversion 16 would have been detected, because this is associated with the CBF beta MYH11. And interestingly, by NGS, it was at second blast crisis that for the very first time during the disease course, we detected a BCR-able kinase domain mutation at 3%. Now, we actually don't know where that clone resides. We can't tell because the clone is too small. But it appears that there could be multiple competing clones that can drive progression, as well as the blast phase phenotype, because we can see that there are different mutations in this case that are usually seen in lymphoid blast crisis. So this was a really interesting patient. He had one of just about every different type of mutation that has been described in CML patients. But it raises the question that if we had known that this patient had multiple clones at diagnosis, could adequate suppression of the clones prevent the acquisition of these other subclones and perhaps prevent progression? And unfortunately, this patient had a suboptimal imatinib therapy. It was only 300 milligrams due to some intolerance over the first 6 months or so. So this is the type of thing that we're trying to learn with the CML Genomics Alliance. And just 2 final patients. So this is showing the clonal dynamics of 2 patients who both had mutated ASXL1 at diagnosis. The first patient had an ASXL1 subclone that we can see in this case disappeared, and the patient maintained a deep molecular response. In contrast, the second patient had rapid blast crisis, also had an ASXL1, but had a second smaller clone. Now, within that smaller clone, we detected 3 mutations. This was a BCOR-L1, and again, RUNX1 and IKZF1. This time it was a novel IKZF1 fusion. And at the time of blast crisis, the clone had evolved, and we detected 6 BCR-able kinase domain mutations and 2 other cancer gene mutations. So in this case, it was this clone at diagnosis that contained potentially highly transforming mutants that drove the resistance. And in this case, we don't know whether treatment intervention would have prevented the progression of this patient. They were treated with 600 milligrams of imatinib and actually achieved a good response early on before blast crisis. But something really interesting that we can also detect using NGS for BCR-ABL kinase domain mutations, because a lot of these mutations occur in close proximity, we can actually see the clonal relationships between some of these mutants. So here's an example of this patient had 4 mutations within the P loop. So these are shown here. And again, each one of these pink rows represents a sequencing read. And we can see that in each of these reads, there is a single mutation. So these kinase domain mutations are each in separate clones, and they're not in compound, they're not compound mutations. So at the moment, NGS has relatively short sequencing reads of about 150 to 250 bases. But in the future, with long read sequencing, we may be able to sequence the whole kinase domain and really determine the clonal relationships between these mutants. So I'm just going to finish there and summarize that BCR-ABL kinase domain mutations remain an integral component of patient management. The gold standard has been Sanger sequencing, and as groups develop their NGS methods, this will still be used in the foreseeable future, but the recommendation is to move over to more sensitive NGS analysis. And NGS on a broader scale can identify additional mutations in these cancer-related genes, and there's lots of different types, not simply single nucleotide variants and indels. And the clinical relevance awaits further validation for evidence-based clinical decisions and to appropriately inform clinical management guidelines. So I haven't given a formal acknowledgement, but I'd just like to acknowledge CML Foundation, the Genomics Alliance, and many people who have contributed to this work over many years. Thank you.
Thank you, Sue. Thank you. It's a great summary. And again, I echo what you say. You know, it's going to be really interesting to see what the Alliance actually does produce and how we can take this evidence into clinical practice. We've got 5-10 minutes for questions. Jorge, I can see your hand already.
Yes. Hi, Nico, and hi, Sue. Excellent presentation as usual. One mutation that we see with some frequency, and somehow I get the impression that I'm seeing it more and more, is this 35 base pair insertion. What's your thoughts about that? What does that mean? What are we supposed to do with that?
Mm-hmm. Yes, this is something that we saw as well as many groups around the world. We did some initial investigations many years ago, and we found we isolated the normal ABL allele, and we found it as well. So this 35 base pair insertion is derived from an intron, and it generates an outer frame fusion. So we find it in BCR-ABL, normal ABL. We think it is just a transcript. It has nothing to do with resistance. There are some groups who have found an association, but that may just be by chance. I don't think it has any role. And in fact, it was more than a decade ago that Tom O'Hare and Mike Dininger's group did some functional analysis, and they published their paper to say that there is no, this 35 base pair insertion does not cause any resistance. So I would recommend that this is not reported. It is a background transcript, I believe.
Thank you.
We have a question come through in the chat. In the absence of a single cell sequencing, is it appropriate to draw the fishplot to represent the mutation clone size and substructure?
Well, certainly that's what we've been doing, and we're actually doing some single cell sequencing on that particular patient to see whether our inferred clonal relationships are correct. And, you know, does it really matter? I think it's of interest. Sometimes it is easy to tell based on the variant allele frequency where these clones sit. Maybe in the future, when we get more knowledge, it may be important, just as we've explained, compound mutations may be have a different resistance profile than individual mutations.
Yes, I would like to ask you, you shown in your, first of all, thank you very much for your beautiful presentation. My question is, all these mutations which are subsequently arising in your patients that you have shown, do you think that they were already present at diagnosis and therefore it's simply a question of sensitivity of the techniques that you have used? Or do you think that they have been acquired while they were already in full remission, as shown in the cartoon that you have presented?
I think both. We've certainly seen some at diagnosis, and we have seen others emerge later. So we're achieving now down to about 1% sensitivity. So it actually would be quite a good project to go back and have a look at some of the patients where we didn't detect any mutations at diagnosis, but they subsequently went on to have a poor outcome. So it would be interesting to go back, and that's one of the things that we would like to do, some more clonal tracking, just to see how early these mutations arise and just how low is BCR-ABL. You know, I mentioned that with BCR-ABL kinase domain mutations, we can test patients who have 0.1% BCR-ABL, but I don't think we will be able to do that for these mutations because we can't isolate them like we can isolate BCR-ABL. But potentially, yes, if we had more sensitive, maybe they are already present.
Okay, so one other question, but when you have shown your slide that if you can go back, so we can see it to the slides, the mutations one, yeah, this one, but at the end of the animation. Okay, so you have shown that, for example, the CBF beta MIH11 mutation is predominant during the secondary blast crisis, but there was only this mutation, also some of the other ones. So were all these which are listed here independent clones, or there was a superposition of different mutation?
No, so what this actually means, and it took me a while to understand fishplots as well, but you can see that the pink is on the outside. So on the outside is the very dark blue, and then the inner is the pink, and the inside that is the white. So this is all one clone. So it's that clone. So this clone that has the CBF beta and the IKZF1 deletions, it also has the U2AF1 and the SETD1B and the PHF6.
So it's absolutely, it's a series of subsequent events causing a higher degree of resistance. Am I correct?
Yes, these are all subclones.
So in origin, there were only the two clones, which were, one disappeared, was XLX1 apparently, and one disappeared, and the other one, the SET1 beta B, and the U2AF1. So altogether, these were the original one. So looking at this representation, don't you think that it'd be nice to start, probably at least for patients who are already at high risk, like of evolution, like I do not know the so-called or the LTS risk of these patients at diagnosis was low or intermediate or high?
Sorry, I don't know. This was a patient diagnosed in 2002, so we wouldn't have had an ELTS, and I'm not quite sure what the SoCal was.
Yes, but it would be nice probably to start with a very strong therapy to try to get rid of all the already clonal, or to stop the clonal evolution of the disease just from the beginning, at least for the patients who are a higher risk of progression.
Absolutely, I agree. I think that could be the key. If you can reduce that BCR-ABL clone very rapidly to a very low level, that may prevent the subsequent acquisition of all of these others.
Thank you. Unfortunately, we have never done, apart of the ponatinib trial that was blocked because of the cardiotoxicity, we have never done a trial. Now there is an experimental trial in France by Frank Nicolini, but with the ponatinib first line, which could be, again, one of the drugs to be used in this condition. So at least a combination of the drugs. Thank you, Sue. A very beautiful presentation.
Thank you.
Thanks. We are sort of out of time, but so perhaps if I could sort of end with one sort of looking into the future. So from your perspective, when do you think it's going to be possible to incorporate genomic risk profile into therapy selection? 5 years, 10 years?
Yeah. I would hopefully well within 5 years. I think the first thing is to have the first clinical trial where patients are perhaps risk stratified and treated based on their genomics. So I think that would be the next step. So hopefully that will be very soon if we can get that organised.
Thank you, Sue. Please, everybody join me, and thank you, Sue, for again an excellent presentation. I know that there were some questions that did come through in the chat, so we will get you answers and post these. Please feel free to join us at the next ICMLF conversation, which will be looking at managing toxicities, and we'll be discussing that in May. Again, thank you for joining us. Thank you, Sue, and we look forward to continuing to work on this.